and welcome to the Waterloo Smarter Health Seminar. I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research. Thank you for joining us today for this seminar celebrating the University of Waterloo's 50th anniversary. In addition to the audience, I'd like to welcome our web viewers and the Ontario Telehealth Network sites. This seminar is being recorded and is being broadcast over the web. We ask that you hold your questions to the end of the seminar presentation so that we can get a real or virtual mic to you. We'd welcome questions from our web viewers and from the video broadcast sites as well. A very warm welcome to our guest speaker, Dr. Peter Norton. We've had some very interesting discussions during the day, and I'm really looking forward to his presentation. I'd like to acknowledge our seminar series sponsors, Borden Lander Gervais, McKesson, Smart Systems for Health Agency, and Healthcare Information Management and Communications Canada. We could not host these seminars without their support. Before we begin, our next seminar in this series will be Wednesday, November 28th. Our guest speakers will be Dr. Stefan Pentanzi and Dr. Yuri Kogalowski from Conestoga College. They'll be speaking on the challenges and issues in developing health informatics programs. This seminar series, as I said, is in celebration of the university's 50th anniversary. The anniversary theme is Why Not? These seminars are dedicated to this theme and explore different why not questions related to health informatics. It challenges how we do things now in healthcare and looks for better and newer ways. So our agenda today is as follows. Professor Dominic Covey, Founding Director of the Waterloo Institute for Health Informatics Research, will introduce our speaker. Peter will then give his presentation, and as I said, please hold your questions until after Peter's presentation and signal to us if you've got a question. We'll get the microphone to you as fast as we can. When you position the mic, just make sure that you get it as close to your mouth as you can so that we can, everybody can hear your question. Now, Dominic, would you please introduce our speaker?
Well, good afternoon and welcome to everyone. Really glad to have you here, both people in the audience here and virtually out there in webland and video land. It's a great honor to have Peter here today. We're comparing notes on when we first knew each other, and I'm convinced it was back in the early 1990s. He has a memory of me earlier than that, which is scary. This is just an example of my learning process. I thought I knew a lot about computers and information systems in the provider's office. I had done a lot of work in acute healthcare for many, many years. Developed all kinds of systems for cardiology, psychiatry, and other things like that. And a group of family medicine leaders got together, formed a team across the entire province to define what an electronic record might look like for a physician's office, particularly for family practice. And I went very naively to this to make a presentation about it, and soon learned that I didn't know almost anything about primary care, and that the nature of primary care records were radically different from the specialist records that I had been used to. So it was an incredible shock to me, and then gradually over time learned about it and learned some of the reasons that we have so much trouble introducing systems, particularly into the interactive environment where a physician and patient are working together. But more than that, to deal with and capture and process the unstructured or minimally structured information that might be garnered during an initial patient visit. So it was an incredible educational experience, and I accuse Peter of being one of the key people to let me know about that. Learned a lot of things about Peter since that time. At the time, he was running a health services organization, a very early one at Sunnybrook, which now has become reincarnated as family health teams. So he was in the vanguard of that type of activity. He ran for the department at Calgary for a number of years. He was a professor in the Department of Family Medicine at Calgary and directed that department. He's also a board member of the Health Quality Council of Alberta. He's a member of the Institute Advisory Board and the Institute of Health Study of Health Services and Policy Research at CIHR. His main interests have been in the area of patient safety, quality of care, and knowledge transfer. And I know that the institute that he's involved with has a strong emphasis on knowledge transfer. He was a principal investigator, where probably you've all heard of him, with Dr. Ross Baker on the Canadian adverse event study, which has so affected the understanding and the awareness of the safety issue in Canada. He's also a founding member, I'm sure he'll tell us about this, of Safer Healthcare Now, which is taking the lessons that were learned in the work related to the adverse event study and bringing it in, as I understand it, to begin changing the way things are. In addition to this, Peter, although currently in family medicine, has a background in mathematics. He did his PhD in mathematics and always wows me. I'm always impressed with real mathematicians. So his background is almost, I think it's unique in Canada, both from the health and the mathematics domain. And I look forward very much to hearing your presentation.
Thank you, Dominic. And thank you to you all for coming, and to the university for asking me to, honoring me by asking me to be part of this series. We'll just pass that by, except you should notice the symbol for the University of Calgary involves a bull. So what I'm going to do is talk about quality and safety of the healthcare system. I'm going to do a brief history of modern patient care to bring the issues of quality and safety into historic perspective. Think a little bit about why adverse events occur in the system, and then talk about what I think the focus should be over the next little while, which is on system reliability, and give you some practical solutions. Certain elements of my talk will turn red. And when they turn red, it's because I think it's a stop sign to think about whether health informatics can be applied to that particular concept, problem, idea, opportunity. And so I'm giving a little list of things that the health informatics folks here, e-health folks, might want to think about as areas to explore. I want to start by talking about quality. We traditionally in healthcare, we talked about quality for a long time, and we didn't really define it very well. And I, as a physician, say, of course my care is perfect. It's quality care. Every patient I see, I deliver quality care to. One of the reasons I think we've had trouble with this is we haven't defined dimensions of quality. And I particularly like this diagram, which defines 6 dimensions of quality in a very special way that are interrelated and I think are all measurable. When you say just quality, you haven't broken it down into small pieces which you can measure and deal with. So this is chunking quality in healthcare. At the bottom, at the base of quality, is safety. Safety is fundamental for a quality system. But above that, we next have patient-centeredness. Interlocked with safety, patient-centeredness means that we are developing a system that centers on the patient and not on the needs of the profession or the Minister of Health. Above that and anchored to it are efficiency and efficacy, then timeliness, and at the top, equity. These are measurable qualities, and I believe they are the 6 dimensions of quality that we should try to measure as we think about the properties of our system related to quality. So I want to move on and tell you what the citizens of Canada say about the quality of our system, now that I've told you how to measure it. This is data from a study done by the Commonwealth Fund in 2004, and they surveyed people in Australia, Canada, New Zealand, the United Kingdom, and the United States. They randomly selected adults. They had to have had a contact with the healthcare system in the last year, and they asked specifically about what happened during that contact, not their opinions of the health system. What happened to you? Questions like, if you were trying to get care from your family physician, did you get it within 3 days, 5 days, 7 days, 10 days? Very specific questions. They looked at a lot of adults. This has very good statistical and methodological qualities. And here are the rankings of the 5 countries with respect to the safety dimensions. Let me warn you that 5 is not the best. 5 is the worst, the bottom. And so Canada came 4th in patient safety, 3rd in patient-centeredness, 5th in timeliness, 4th in efficiency, tied for 3rd in effectiveness, and 4th for equity. That's what the citizens said we did. Compared to the other countries, based on real encounters with the system. Now, you can look at this two ways. You can say, this is horrible, or you can say, gosh, aren't we lucky we're not like New Zealand? New Zealand has very little room to improve. And we have a huge opportunity here. Just to show you this data isn't particularly unique, I want to tell you about work we've done at the Health Quality Council of Alberta, which is an arm's length organization funded by the province to inform Albertans about the quality of care in the province. We've done population-based surveys in 2003, 4, and 6, and we asked people, based on your interaction with the healthcare system in the last 12 months, did you or a family member have harm caused to you by that encounter? Harm from the encounter. The number is 12, 13, and 14. No change over the 3 years. So the citizens, whether they're Alberta or all of Canada, are not saying that we're doing a wonderful job. But do we have real data that is less population-based and more intimately based on individual encounters? And to answer that, I want to talk about the Canadian Adverse Events Study, which Dominic mentioned. This study was funded by the Canadian Institutes for Health Information, the Canadian Institutes of Health Research. We started this project in 2002 with about $1 million worth of funding, and we published the results in May 2004. This was a huge health services research project involving over 40 investigators across the country. To understand this study, I have to tell you what an adverse event is. Thumbnail, adverse event is a bad outcome from care. Technical definition developed by Ross Wilson from Australia, which is used now across the world, is an adverse event is an unintended injury or complication. So that's one condition, unintended injury or complication. With a bad result, it has to result either in disability, death, or prolonged hospital stay, and it has to be caused by healthcare management, not the underlying disease. A complex definition that is slowly creeping its way into our day-to-day conversation, even in the press in Canada. What we did to do this study was look at acute care non-specialty hospitals in Canada that were reasonably large. We randomly selected charts for adults who were discharged from the hospital in the fiscal year 2000, and we carried out a two-stage retrospective chart review involving trained nurses and physicians. The first stage is the health team walks into the institution and has a pile of charts, 250 charts tall. That goes up to the ceiling somewhere. And the first thing is the nurses look at those charts and, using explicit criteria, sort them into two piles. The kind of criteria the nurses use are things like, did this person have an unexpected return to the operating theater? Was this patient readmitted within 72 hours of being discharged, unplanned readmission, and so on? They put the charts with these particular criteria in one pile, and they put other charts in this pile that don't have criteria. What we've done with that is to make this fishing hole more stocked with fish, the adverse events. And we're going to use physicians who are expensive to search through these charts to find adverse events. And the physicians then do that. They have to figure out if there's adverse events and if they're preventable. Here's what we found. The overall adverse event rate in Canada in the year 2000 was 7.5%. That meant 1 in 13 adults hospitalized in general acute care hospitals in this country experienced one or more adverse events. And about half of those patients, 2.8%, had a preventable adverse event. We actually, if we had just done things a bit differently, could have prevented that happening. Preventable adverse events are the same in all three kinds of hospitals in Canada. Little hospitals, big community hospitals, or teaching hospitals all have the same preventable adverse event rate. An estimated 1.5% of Canadians hospitalized in 2000 had an adverse event and died The adverse event contributed to their death. Many of these patients were very sick and would have died anyway, but the adverse event hurried them along, and that's not acceptable. That comes out to about 16,000 people in 1 year. And finally, in a standard 500-bed hospital in Canada, there would have been about 100 preventable adverse events each month. Detecting adverse events is difficult. You can see here data put together by a colleague, Phil Hébert. Traditionally, we try to find adverse events in hospitals by looking at incident reports, which are filed by nurses and physicians and other healthcare workers. This gives about 5 adverse events per 1,000 admissions. Retrospective chart audit, which is what we did, gives 30 to 70 adverse events. But go down to the bottom. If you automate flags that come up and say, let's look at this chart, something you can find by mining the electronic data that says, look at this kind of chart, you can push that all the way up to 55. And if you combine that with daily review of charts by experts, you can get 130. Now remember, we got 75 out of 1,000. So what is the right number? The right number is probably around 25 to 30%. 1 in 3 to 1 in 4 admissions have an adverse event, the way I defined it. This is a huge opportunity here, detecting adverse events for the e-health movement. As we collect data in a more systematic, thorough way, it is quite possible to design those systems to make the detection of adverse events, in my mind, to make the detection of adverse events a routine thing, so that we can learn from the adverse events to make the system safer, and so that we can understand what the underlying burden of adverse events is on the system. So I want to go on to why adverse events happen, and what's going on here? Are we really messed up or what? And to do this, I'm going to put it in historic perspective. If we go back to the period between 1860 and 1910, we see the emergence of modern medicine. We define the organizational and physical structures that are presently in place in our hospital system during this period. They haven't changed in any substantive way since. And in particular, they're not automated. During that period, we defined new high standards for clinical education. We actually instituted professional licensure for the professions. We began to focus on on scientific research, clinical practice focused on that, evidence-based practice, and we developed the organizational structures for hospitals that are still in place. You might say, well, why did we not change it since then? We didn't change it since then because it's pretty good. It works. It saves thousands of lives every day in this country. We have bypass surgery now for people with bad hearts. We have trauma surgery for people that would surely die without it. So we have good systems functioning well, but they're a bit antiquated, and when they get antiquated with things like information explosion, they just don't work very well. I just throw this in because it's cute. Professor Henderson, who is a senior professor at Harvard of health history, medical history, called 1912 the Great Divide. For the first time in human history, a random patient with a random disease consulting a doctor chosen at random stood better than a 50-50 chance of benefiting from the encounter. And that was because the new hospitals were here, at least in part. New drugs, new hospitals, and other things. But things have changed a lot. We've had an information explosion. We have new and better drugs. We have new and questionably better diagnostics. We have emerging diseases and disease patterns, increasingly complex surgery, and a huge shift to moving to the community. We've got the same structures we had in 1910 with new complexity. There's a misalignment between the structures and the complexity. This is a nice set of challenges for e-health. Can we, using information technology, moving information around better, deal with the pressures on the system that exists? I just show you a few things to make this very concrete. The Merck manual is a nice little manual that would be a minimal data information source for a family physician. In 1899, it was 192 pages long, and in 1999, it's 2,833 pages long. There's a lot more information than there was back when we designed the systems we're working in. Drug knowledge. 30 years ago, when I graduated as a generalist, I needed to know about 60 distinct drug types. Now the number is close for the residents that graduate from my program to 600. The cognitive psychologists have clearly shown us the kind of detailed information that you need filed on these drugs in a human mind is limited to about 100 to 150 for easy retrieval. There's a little gap there, right? Now, does that gap look like it's an e-health possibility? I think so. New tests. Here's something going on about new testing. Molecular diagnostic testing, that's that stuff about genes. We've got the right genes or the wrong genes. It's exploding nationwide by more than 20% annually. It goes up 20% annually. By 2009 in the States, there'll be 67 million of those tests done, flowing across physicians' desks. Just more pressure on the docs to interpret, to talk, to teach. I think that this is a huge opportunity for e-health to help with handling this information, streaming it correctly, and making sure that the patients are partners in a patient-centered model with access to this data and using the physicians correctly for the interpretation. Better tests. I put question marks around it because as we see the number of new tests increasing, we get more and more false positives. Tests says you might have prostate cancer, but of course to the patient that means I do have prostate cancer. That's very expensive. I have to do more tests. I have to stress the limited resources of the system. I cost money. I increase waiting time. Maybe by filtering this, using it correctly, engaging the patients in the information, we can do something better. Emerging diseases and disease patterns, huge problems. Let me just speak briefly to the diabetes epidemic. It's easy to project that in Saskatchewan, which has the highest percentage of natives, Aboriginal people in Canada as a population base, if we don't get something done about taking care of diabetes better, it will eat the whole health budget by 2020. All of it, taking care of the diabetics. Because diabetics get sick. They get renal disease and they get heart disease. Complex surgery. It's unbelievable what I've seen in my lifetime. I was trained, we hadn't done open heart surgery. Now it's routine. I was trained we'd never transplanted a liver. Now it's routine. Now, don't you think that there's a huge amount of information flowing around patients with these complex procedures that we should be handling better? And the shift to community-based care is very scary from a family doc's perspective. Just talk about pneumonia. I can take an 80-year-old person now who would have a 70% chance of dying of pneumonia 30 years ago and treat them as an outpatient because I've got better drugs and better home support. But I never hear from the people taking care of them in the community. I'm isolated because we don't move the information around. So we have an old system that has and continues to work well, but there's increasing pressure and complexity, and it must change or we're going to have more and more adverse events because the complexity breeds adverse events. Why do they happen? Humans make errors. The fundamental thing is that we're pretty poor machines. Mark Twain had it all figured out. Man, a creature made at the end of the week when God was tired. We haven't evolved very much. Our brains can't do things. I already showed you the problem with the drug stuff. We know in other human endeavors the machines have helped us. I would say that they have to help us here. The reality is that most errors are made by good people with good training, skills, and intentions who inadvertently commit errors despite their best efforts because of an unfortunate confluence of individual, workplace, communication, technological, psychological, and organizational factors. That's what's happening. That's why we have 7.5% of people having adverse events. And it's a combination of the humans making errors and the system not being very robust to catch those errors, to stop them going through and harming people. So a human dimension is cited as a contributing factor to 60 to 80% of adverse events, and a system error, a system misfunction in about the same number. So most of them have both. And so we can't change the human condition, says Jim Reason, one of the founders and fathers of patient safety. We can't change the human condition. The only lever we have is to change the conditions under which humans work. And one of the things we haven't been successful about is getting information technology that is useful and accessible at the bedside when I'm taking care of patients. I'll just move that. And so one way of thinking about this is to focus on system reliability. Reliability of a system is defined as, in the healthcare system, is defined as patients getting the intended tests, medications, and informations and procedures at the appropriate time and in accordance with their values and preferences. That's a pretty good goal for the system. It involves all of those quality dimensions are buried in there. We measure reliability as defects per 10. So 10 to the minus 1 would mean every 10th time you do something, you have a defect. You don't quite miss this. You make this reliability. 1 in 100 is 10 to the minus 2, and so on. If you combine the studies saying how reliable the healthcare system is, it's 10 to the minus 1.36. This is not an outstanding example of reliability. And in particular, the adverse event study tells us something about the reliability of hospitalization. Now, it's unfair to compare hospitals to other industries. For example, the nuclear power industry or aviation or any big industry. Why? Well, I think it's better to think about what the system would be like if we didn't have hospitals. That shows us how much good hospitals are doing. If one of you has a niece or nephew who's playing hockey tonight and gets boarded badly and ruptures their spleen and the hospitals are closed, that person is going to die. And if the hospitals are open, that person's going to live. It's that simple. The surgeons will fix it. There will be 4 to 5 young men and women in Canada who have a ruptured spleen before Christmas, and all of their lives will be saved from hockey. Hospitals are great. So you shouldn't compare them to flying airplanes. Now I'm just going to do that because it's sort of fun. I want to take you through this risky activities in Canada diagram. Let me point out a few things to you. First of all, up the upwards axis, the y-axis, we've got total lives lost per year. Notice that the scale is what we call logarithmic or exponential. It doesn't go up like 1, 2, 3, 4. It goes up like 10, 100, 1,000. It goes up really fast. And across the bottom, we've got the number of encounters with this particular activity to get a fatality. Now, safety experts divide activities into 3 types. Dangerous activities, where 1,000 or less encounters produces a fatality. Regulated activities, where something between 1,000 and 100,000 encounters produce a fatality. And ultra-safe activities, where over 100,000 encounters are required to produce a fatality. The lines are important because safety science has shown us to cross from one region to another requires system redesign. You have to work differently. You can sort of move inside these categories and get a little better, but you can't move across a category without changing the way you work. Okay? So here's some Canadian stuff. There's commercial airlines. They're ultra safe in Canada. This is all Canadian data. If you go back to when we first had commercial airlines, they were back close to the dangerous area. What kind of things have we done? Remember I said to move across those barriers requires system change. Well, one of the big system changes was ground control. When we started, we didn't have good ground control. Now we know where every airplane is at every moment. And so if 2 airplanes are doing this, what does ground control say? Do that. That's a fundamentally different way to work. It wasn't the pilot looking out the window anymore if someone tells him on the ground you're heading toward another airplane before he sees it or she sees it. I put in firearms because I come from Alberta where there's some problem with the gun registry. I don't know if any of you watch that political thing. But we can fire guns a lot of time before we kill someone in this country. And we spent a lot of money trying to make that system safer. Here's some sports. This diagram comes from the same Philly Bear, and he's got a little perverted sense of humor that you can see in that last sort of scuba diving's upside down, right? And notice bungee jumping is pretty safe in Canada. Now, this is not quite as safe if you go to New Zealand where they jump into canyons, you know. You know where we do all our bungee jumping? We do it down at the CNE, you know, and it's all very controlled, right? Canadian National Exhibition. That's where we do it, and that's why it's safe. But rock climbing, which we do a lot in Alberta, is pretty dangerous. The units here are 25 hours of rock climbing. And if you do that 1,000 times, someone dies. Oops, sorry. Here's a bunch of our primary industries. Unfortunately, we don't have a good figure for farming, so it's not on there, but it's probably down close to the dangerous area. It's important around here. It's a very dangerous activity, farming. They, for example, pick up those big irrigation pipes and sometimes hit a power line with them. Or they turn a tractor over in a rut. We see a lot of... But we do have coal mining there, which is sort of interesting. 100 years ago, coal mining was down in the dangerous area. It's now in the regulated area, and we fundamentally changed the way we coal mine in the last 100 years. Before, we used to go down underground, and now they mine it by using big machines on top of the ground in Canada. And so there's a couple of examples showing the kind of change you have to move across a boundary. Whoops. And there's driving, something we all do every day. And we don't even think about safety for that, right? We just think, do many of you sort of get into a cold panic, except when you get on the 401? I mean, I come from Alberta. Things are simple. So you can average this, and you can say that area down there is acceptable public risk. That's sort of an averaging figure in a technical sense. And so that's what we will accept. We don't regulate away any of those things. We don't say you can't go rock climbing or you can't drive your car. And unfortunately, there's hospitalization. There's hospitalization. So my goal is to try to put enough things in place so a generation from now we've moved that to regulated. That's my goal. Now there are 3 types of reliability. Overuse, it's using too many tests, procedures, drugs, surgeries. Underuse, not using things you're supposed to use. And misuse is using them inappropriately or wrong. And at least these first 2 are just set up for e-health. Because if we knew that Mrs. Smith had just had the blood test done last week and could get our hands on the blood test, we might not get it done again. And I'm sure none of you have ever had a test done twice in a week because the docs and nurses couldn't find it. The information's in a mess. So the bottom line, I think, is in the next generation, we should aim for a safe, effective, patient-centered, timely, efficient, and equitable system. What that means for you as a patient, whoops, I really want to go the other way. There will be no needless death. There will be no needless pain or suffering. There will be no unwanted waits. There will be no helplessness. There will be no waste for anyone, for you, your family members, the public in general. So how are we going to do that? What are the practical solutions, and how will e-health help with those? I'm quoting here from an interesting paper by Larry Biro, which reviewed the solutions for producing change in the healthcare system. And he defined consistently effective interventions. Outreach education visits. This means going out and educating health professionals close to the point at which they do care on a one-to-one intimate basis or small to one. Reminders, particularly manual or computerized, things that come in my face when I'm starting to make an error. Multifaceted interventions combining two or more of the following: audit and feedback, giving me some feedback about my performance as a physician. Reminders, local consensus process, getting all the docs together and saying this is how we're going to do it, so they actually have reflected on how they're going to do it, or marketing directly to them as the drug companies do. And finally, interactive educational meetings. This is really not this kind of a meeting. This is called talking heads. I'm talking about getting people to work at a meeting, form a consensus, work in small groups. So those things work. Two of those cry out for more information technology: the reminder system, flagging things in front of me, and multifaceted interventions, in particular audit and feedback. Means I can get the data out quickly and tell me, Norton, last month you missed the following 3 tests in your diet, all the diabetics you saw. I don't know that. I can't even find that right now. Is that amazing? Practical solutions. These are now the interventions of variable effectiveness, audit and feedback by itself without something else going on. That's just a clinical summary of my performance, audit my practice. The use of local opinion leaders. This is practitioners who are influential. And the drug companies, when they come around and try to convince me to use a new drug, say, you know, Dr. Smith, the eminent cardiologist, is using this. Subtle message: you're a dope, Dr. Norton, because you're not using it. Local consensus process and patient-mediated interventions. I actually believe that patient-mediated interventions, engaging the public, is much stronger, but we haven't done the science to show that it's strong. But for sure, 2 of these, the audit and feedback, as I pointed out before, and patient-mediated interventions, cry out for information technology. Patients now often can't get their health information. That's solvable, because it's almost all sitting electronically. So why shouldn't they have it? They own it. Technically, they own the information, but they don't know how to interpret it. And when they go on Google or something and look up, you know, high magnesium, they won't be able to separate the wheat from the chaff. They won't be able to find information that is accurate and helps them know whether they have to come to talk to me. So there's some issues here about expert systems to help patients interpret their data that I think needs to be investigated. There are interventions that have little or no effect. Educational materials, for example, clinical guidelines, and a lot of the stuff we do for health professionals, and meetings such as this. So I came up with a whole list here of e-health opportunities, which I've just listed there again. I think the future is ready for moving forward in information technology. I think it has to be done in a slow and cautious manner so that we don't lose any of the gains we have made in hospital and community-based care, but we just enhance them and try to close that gap in the next generation. E-health's not a magic bullet. The solutions must preserve the powerful clinician-patient interaction. Don Berwick, a bright pediatrician who's led quality improvement and safety in the United States and the world. If you think a computer will solve your problem, you haven't understood your problem yet. You haven't got the problem right. The computer's bolted on to solutions. And so you that are working in e-health should be saying, how can I work with clinicians so that their solutions to the clinical necessities are designed so that I can bolt on the technology. So there's a dialogue that has to occur here that is not occurring. It's a big agenda, and I like to just finish with this quote from Winston Churchill. Every day you will make progress. I hope all of you will. Every step may be fruitful. Yet there will stretch before you an ever-lengthening, ever-ascending, ever-improving path. You know you're not going to get to the end of the journey, but this, so far from being discouraging, only adds to the joy and the glory of the climb. That's the challenge. That's what we should be doing. Thank you so much for listening.
So, Peter, thank you very much. We have an opportunity now for both in the physical audience and in the remote audience to ask questions or make comments or pick on Peter any way you want. It's a real opportunity. And just put your hand up so I can get you the microphone. Okay.
Hi, Peter. I'm just curious. You were talking about the patient-mediated interventions, where we have a big push right now by companies like Google and Microsoft to move towards patient health or personal health records and engage the patients more directly. And it seems to be outside of the mainstream of the work we're doing in healthcare and e-health and everything like that. What are your comments or cautions with respect to some of these movements that we're seeing right now?
Well, let me say, first of all, some of the stuff that's going on externally is looked at as a safety profile so that you've got your record to give to other professionals when you travel around. I think there was something in the paper today, an editorial. I don't know if you saw it. But let me talk. Let me tell you a story about engaging patients in a different way, which was a huge learning for me about the cautions I have around this and the fact that I actually think there's basic science almost to be done here. One of the dangerous places in hospital systems is the neonatal intensive care units. You've got very fragile little babies with lots of tubes in them usually, lots of interventions occurring, a lot of time pressure on getting things right, very narrow bounds of safe physiology for them, much narrower than for adults. So it's a complex, difficult place to work. And each baby has to have his or her medications adjusted for the weight and the body surface, depending on which the medication is, in complex calculations. We thought we should make this system safer in Calgary. And we thought we had a brilliant intervention, which was to use our clinical pharmacy time, part of it, to educate patients and family members of these babies about the medications that the baby was going to receive. It's one of the most dangerous things, is getting the right medication in. And so the pharmacist was to spend time with the families and say, this is what the medication is, this is its name, this is what will be printed on the little mini bag that gets hung on the IV. This is the time it's supposed to be there. This is the size of the bag. This is what this drug does. And this is the potential side effects. So if you notice any of these in your child, please call the nurse over immediately. That's a really smart sort of safety idea because it puts another barrier against harm in our process, right? In addition to the nurses being very careful and the pharmacists and the physicians, we now got a parent watching. And so every time someone watches, there's less likely that a mistake is going to go through and cause harm. And so we introduced this program. We talked to the nurses. We talked to the pharmacists. We reassigned work patterns. We talked to patients. We had a patient advisory group. The thing fell flat in its face. Flat. Because we were evaluating it. So we did what good researchers always do. We debriefed, using qualitative techniques, the families and the nurses. That's where the interface occurs, because the nurses give the drugs and the families are at the bedside. So that was it. Well, summarizing what we were told, the family said, we don't like the program because we're concerned about reprisal if we criticize the nurses. When I'm not there, will that nurse watch my child carefully enough? Maybe not even consciously, maybe subconsciously, the child will get a black mark and get less attention. They talked like that. The nurses said, we don't like this program because it attacks our professionality. We're professionals. It's our job to get this job perfectly right, and we just don't like other people watching over our shoulders. So what was my learning about that? My learning is that this is more complex than simply giving the information out. or even giving it out with interpretation. That if we're going to get this to work, we're talking about changing culture, inbred cultural patterns. And to do that, you've got to work very carefully in small steps, slowly. We know about changing culture. So I think a solution that is just will do it is probably wrong, and we need to do the basic science to understand how to do it. So the how isn't just getting the information to them. The how is engaging the team with the patient at the center and the health professionals around them in using this the correct way.
Here, while we're waiting, I'll ask you a quick, could you have a quick overview of the Safer Healthcare Now initiative that you've got underway?
Sure. We, having done the Canadian Adverse Event Study and producing some momentum for safety in the country, decided to launch something called Safer Healthcare Now in April of 2005, about a year after we got the study out. What Safer Healthcare Now was, we took 6 interventions. We borrowed them from the States, actually, the list. Very non-technical interventions that had evidence-based that could make care of better quality, higher quality and safer. Let me give you an example of one of them. There were 6, so I'll talk about one for a second. One was called surgical site infections. When you're having elective surgery, one of the things we want to do just before you have the surgeon cut open your skin is to inject some antibiotics, and it has to be in there long enough to get lots of antibiotics in the tissue where the cut's going to be, so that when the knife goes through, if there's any germs on the surface, they're killed as they go down to where the surgery is going to occur. Makes sense, right? We've known that that is a substantive thing, it's got what's called grade A evidence for reducing infections after the surgery. We've known that for 20 years. So you have to give this antibiotic on time. It has to be there for a little time in advance. There's a small window to give it. In Canada, when we started this program, only 40% of patients were getting that antibiotic at the right time by the right route in 2005. There are some other things that are in this package of things that we're going to try to do for patients. One is, these are little health hints for you if you go to the hospital, and you need to get your antibiotic, ask. Number 2, make sure if they're going to clean up your skin that they don't use a razor, that they use a clipper. Why? Because when you shave the skin, you nick it, micro nicks, and guess where the little germs hide? In the micro nicks. So you get more infections after your surgery. Number 3, if you're having these are technical. If you're having bowel surgery, you've got to have your temperature normal all the time during surgery. You tend to cool down because they've got all this stuff open in here, cools. And number 4 is if you're having cardiac surgery, that your sugar is in the normal range throughout the operation. So those are low-tech things. As I said, we started with performance in the first indicator at about 40% across the country. And there were 5 other interventions, and I'll talk about one more of them in a minute. But they're all similar. They've got the same flavor. We had hoped to sign 100 teams up within a year. We have 700 teams working across the country. We've now got about 100 teams. Teams are based at a hospital or a region. There are regions in the West, a little different than this part of the country. And they have now succeeded in producing a change from 40% of the patients getting an antibiotic up into the 70, 80%, and they're heading for 85 to 90, which is the theoretical limit. Some people can't take antibiotics because of allergies and things. Another of the interventions is called central line infections. Central lines are the things we poke in through the neck often, and you see them in cancer patients and ICU patients. They're big things. They're going in close to the heart. They're quite aggressive lines, and we need those because sometimes if a person's in the ICU, we use up all these veins, and we need to get in here. So we go into big veins and big arteries. They're called central lines. And there's it's one of the things is to reduce central line infections. So infections associated, once you puncture the skin, you're at risk of infection. The intervention is very simple. It's better cleaning, better changing of the line, and a slight change in the line. Very simple things to do. Class A evidence wasn't working. We have 16 specialized pediatric hospitals in Canada, like the Hospital for Sick Children. There's 16 of them altogether. As a group, they took on this in their intensive care units, where's little kiddies. And all 16 of them started about 18 months ago, maybe 20 now, 20 months ago, trying to institute this bundle of change. And they're supported in Safer Healthcare now, supported by many mechanisms, including measurement mechanisms and quality improvement mechanisms and networking them together by teleconference and bringing them together as for face-to-face meetings, so learning from each other. When these 16 hospitals began, they had 2.3 central line infections per month per hospital. A central line infection in child costs about $30,000 and has almost a 30% mortality. So there was a substantial burden going on with these. We now have 6 of them that haven't had one for 6 months. So we've demonstrated in Safer Healthcare now that we can make substantive changes that have impact, that save money, and that save lives. But we're sort of picking away. We're moving in that first zone. And there's nothing wrong with moving in the first zone. We should move as far as we can in the first zone. So if it's your child who's in the ICU and is getting better central line care, you should be very happy that we've done that. But that's not quite the same as moving across, which is where I think we will need some things like IT, technology, organizational change, restructuring the way we work.
Peter, I just a comment in the question, and the comment comes after your the anecdote you gave us about the nurses in ICU with parents, and just an observation is that there's an incredible paradox in healthcare where you have these incredibly skilled, very talented people working who seem to have lost sight of your quality pyramid, which has safety and patient-centeredness at the very base of it. And so, I think back to your observation about these programs which are coming outside healthcare and helping to sort of guide people's longitudinal health records. I think they're coming up and they're occurring because of this barrier. And so it's the reason why I think this year in Canada in particular that the internet has now overtaken physicians as being the primary source of sort of health information. And I think people are just sort of innovating around that barrier. So I think it's really, we need to do something about that. But my question was about your survey, whether you actually categorized any of the data that you collected so that it was sort of in sort of a low level versus a high level risk situation. You describe these situations where everything's cascading at once, where pressures are dropping and you've got multiple people working in a team versus those things those mistakes that were making which weren't under pressure. Was that data collected? Because it would seem to me that there would be some interesting observations out of that.
Let me say one thing about these incredibly dedicated health professionals, because I agree with you, they are, and they work hard as they can. And the nature of healthcare is to focus very much on the individual encounter with the professional and the patient at that moment. And as a health professional, you work so hard that you can't see what's going on around you. And we've become very adept at doing what are called workarounds. So if things aren't working, we just get around it, and we don't realize that that's really an adverse event brewing. When we tried to talk about quality as the big concept, people all said my care was quality care. Now we're trying to break it down into chunks which you have to face. And let me tell you, every practitioner has faced the safety chunk. But we still haven't trained them, and I'm not sure we should, to do this thing about stepping back and looking at the system they're working in. If I could be a little clearer about that, when I talk to nurses, I say, I have a definition of the successful nurse on the medical unit. A successful nurse is the one that knows where the one blood pressure cuff that works is on that unit. And they all laugh. Now that's a pretty bad statement about the state of the system. The state of the system is that we can't guarantee that those nurses have a working blood pressure cuff available because somehow the system isn't working. In the Canadian Adverse Event Study, we found 255 patients with one or more adverse events in about 4,000 chart reviews, just under 4,000 chart reviews. For each of those, we have detailed narratives from the reviewers. We don't have the charts. That wasn't allowed by ethics, but we have detailed narratives which have been looked at. There is a range from simple things that just keep you in hospital 2 or 3 days more. For example, not arriving at a diagnosis in a timely fashion because the X-ray report doesn't come up to the floor on time, and so the patient's definitive treatment doesn't start for a couple of days. And so that's an adverse event because it prolonged the hospital stay. And that's a fairly simple adverse event. You might say it's just a little glitch. But then you see the catastrophes. Here's an example of a catastrophe. Mrs. Smith is a patient who is well known to the institution. She's an elderly lady who is having congestive heart failure. Congestive heart failure means your pump isn't working as well. And so sometimes you get back pressure. And the back pressure comes into the lungs. And the lungs get wet. When the lungs are wet, you can't breathe too well. And people like that sometimes make several trips to hospital because in the hospital we can adjust medications and so on to reduce the fluid load on the heart and give it a little sort of stimulus and it'll beat better. Here's a story of a real Mrs. Smith that occurred, which is the catastrophic chain of events. So Mrs. Smith's admitted, diagnosis is correct, and the medical treatment is to push the fluid out of the body. And when you push the fluid out of the body, it's like you've got a bullwhip, Indiana Jones on the kidney, crack in the kidney. That's how you get the fluid out. And somehow, people aren't watching the kidney too well. We have some tests, blood tests and stuff, that tell you if the kidney's tolerating the whipping. And they miss the fact that the kidney isn't. And when the kidney starts having trouble, your potassium rises in your blood. It's one of the first things that happens. And if you've got a heart that isn't too stable and you might be on some drugs, that when the potassium goes up, the heart starts beating irregularly. And now you've got a weak, floppy heart beating irregularly. And guess what happens to Mrs. Smith? She has a heart attack and dies because she's old and we can't save her. Totally preventable. Because we can handle the rising potassium if we see it, but we missed it because we were doing that concentrated thing. But that's a cascade. It started with something very simple, like a lab report not getting up on time, and cascaded down to no one recognizing in time to stop it. I don't know if that helps. I don't know if I answered.
This is more whether you had categorized them in that way, because it would seem to me that there are some very simple fixes to some things, more administrative, whatever. There are others which are going to be so much more complex to solve. So there's a high percentage of those, that the IT might help, but it's going to take a long time.
I agree. And I think we must be very cautious. And I would say early in the IT solutions, we should look for quick wins. Quick wins. There's enough quick wins. I don't call them low-hanging fruit anymore. I think we got most of that, but there's still quick wins. You just have to reach a little higher, maybe a short step ladder. I think attacking some of the problems, there's real basic science gaps. And I'm not sure that isn't true about how we engage patients. I know it sounds funny to talk about engaging patients, but I think that's the basic science of health services research or cognitive psychology and stuff, and sociology, networking, and all that stuff. And we need to build those teams and do some of that basic work. So I think we got to do these things in tandem.
Tony, for 20 or so years ago, to advance my knowledge in environmental health, I took a course in the School of Hygiene at the University of Toronto from Harding La Riche on hospital infection control. And I advocated at the time that there's need for more external auditing, and suggested, among other things, that there needed to be even regulations for infection control in hospitals, and perhaps could be administered by health units if they upgraded themselves appropriately. Today, medical officers of health get involved in hospitals only when there's some significant outbreak. Routinely, I think the inspectors visit the cafeteria, but beyond that, there is little intervention. The costs of infections, as you point out, are extremely great. So I feel we can't do too much in this area. I guess what most of us fear when we go to hospitals, however, are the increasingly developing virulent strains of microbes that are there both because of inadequacy of procedures within hospitals, but because of external events too, overuse of antibiotics in agriculture, with the aged, perhaps, and so you get these virulent strains. There could even be an inventive process here, which I won't get into. So really, I think a lot more has to be done to ensure we have a lot less risk in picking up one of these microbes, either as a patient in a hospital or even as a visitor. And do you have any thoughts about further things that could be done? I mean, you've touched upon this a little bit. Do you agree with the idea of more effective external auditing, even involving health units and medical officers of health and their inspectors? I mean, part of the problem has to do with the physicians who don't want to be told by those with lesser education what to do, and the problem, of course, they have with their view that germs don't grow in the hands of God.
Well, I'll make three comments. One is that Safer Healthcare Now has just announced its next set of interventions, and one of them is directly related to antibiotic-resistant organisms, in particular MSRA, methicillin-resistant Staphylococcus aureus, which is one of the bad ones. So we are trying to take it on in a systematic way across the country with teams. Number two, we have just launched through the Canadian Patient Safety Institute a national hand-washing campaign. There will be information coming to the public. This is in coordination with the World Health, which is trying to do World Hand-Washing Campaign. Is hand-washing effective? Yes, it's not the be-all and end-all, but it certainly helps. And if you are going to be a patient yourself, I don't think there's anything wrong with asking your doctor or nurse if they wash their hands before they touch you. That's patient engagement. Well, let me finish. I have one more. And then you'll need the microphone back if you're going to say more. Number three, on a more facetious note. So number three, on a more facetious note, possibly, interesting study about 2 years ago showing that male physicians shouldn't wear ties because they spread germs. So I don't know if you want to, so you notice I don't wear a tie. White coats. I mean, but it's clear you understand what's going on with the tie, and then the white coats come into it. Should we regulate this more? I think we probably need some regulation, but I think in addition we need to put performance standards on our institutions. I think external regulation is a very low-level thing, and I think that the internal standards should be set much higher than that by institutions, and I think that's the way to go, and that's where we're trying to head with Safer Healthcare Now. So it's a complex problem, though, and it's not going to, it's easy to say it'll just go away. I could add to that, in the surgical site infection initiative that I told you about in Safer Healthcare Now, of course, you start the antibiotics, but you'd like to stop them on time. You only need them for 24 hours. You don't need them past then. And even today, our best functioning teams, averaged out over them, only are stopping it about 60% of the time. So we haven't been very good at getting it stopped. It seems harder to get that step done than getting it started. Now, I want to get it started first, and then I'll try to get it stopped. So we're working on that right now. So you can find lots of examples. I'm not as familiar with the agriculture examples, but I know there are people worried about that, very worried about the effect from agriculture on the bad pathogens. And I know people are working on that. But it shows how complex this problem is. It doesn't just involve doctors or hospitals. It involves multiple sectors. And so if we don't get somewhere, we're going to pay for it.
Referring back to your comparison or non-comparison to the airline industry, there are some, I agree that you can't do a direct comparison, but I think some of the methodologies that have been used to make the airline industry much safer are something that can be introduced in medicine. It's going to take some culture changes. That is the reporting of incidents, and there's a real problem there in terms of the culture. And one of the things that has happened in terms of the FAA and those sorts of organizations is they not only report and investigate incidents, they report and investigate near misses, which is harder to do, I think, in medicine, but you need to have some sort of focus on getting it before you've got a disaster on your hands. My own particular interest has been historically, because I'm a pharmacologist, is adverse drug reactions and interactions, and I think there is the opportunity for technology to be a good input in that regard.
Yeah, if I could say something about learning from the airline industry. I think there are definite places in medicine we can apply learnings. The more technical areas are more amenable to the technical solutions from the airline industry. So things like ICUs and ORs are particularly in ERs, where we are doing a lot of technical medicine, are probably more likely to learn from aviation than low-tech places like psychiatry and family medicine. Having said that, I'll tell you two things that are going on that are direct imports that are useful, apparently useful. One is surgical debriefs. These are taking off pre-briefs. These are taking off across the country. The idea is the surgical team stops prior to cut, and they review the case. The surgeon says something. They're usually very fixed scripts. The surgeon says, "This is Mr. So-and-so. This is the operation. Does everybody agree?" And then there's a and does anyone have things to say? And they go around the room. Then the next question is, what can go wrong today? And people go around and say things. And of course, it's a fixed reflective time prior to getting into the intense work, very similar to what the pilots do when they walk around the airplane before it takes off. Checklist. And we haven't, some places are using checklists, some are just using a formal conversation. And it has turned out to be appealing to the teams after you get past the cultural change that we're going to do it. And it's going to take an extra 2 minutes, or 5 or whatever they spend. So this is taking off across the country. Second thing that is appears to have promise, although we haven't got as strong evidence yet that it's making things safer. It's certainly reducing some pressure. So it's called SBAR. SBAR stands for, is an acronym for situation, background, assessment, and requirement. To give you the background for SBAR, you can say it comes from crew resource management in the military and the airline, which says we've got to learn to talk together and remove hierarchies in care and stuff. And so this has been reinvented, if you like, so that it fits medicine. Again, in highly technical or urgent situations, it works best. Here's the background problem. We train nurses and doctors in different ways. Doctors are trained to do what's called diagnosis. They go to a problem, they diagnose a problem, and they do a solution. That's how I train doctors. Nurses are trained in a holistic way and in an oral storytelling culture. And it's very good because they end up as patient advocates, understanding the patient and putting them in the center. And together we work very well most of the time. But when we don't work well is when I'm on call and it's 2 in the morning and I'm in sleep and the phone goes off and it's nurse Bill on the phone, and Bill says to me, Dr. Norton, I'm phoning you about Mr. Smith. You remember Mr. Smith. Mr. Smith's wife was the one you talked to yesterday. And, she's the short little lady with the gray hair. And, remember she was in with her niece. And Mr. Smith, remember we admitted him 3 weeks ago. And he's really not been very stable. And we thought he had pneumonia, but now we understand that he probably has something more complex. I think you said maybe Lou Gehrig's disease. Well, here I am sitting with the phone saying, just tell me if I have to put my pants on and come in. It's driving me crazy. And furthermore, my anger may come out and that'll drive Bill crazy. Because for Bill, he's doing what he's supposed to do. So let's structure this conversation so that it meets both our needs. And so we train people to do this. We're doing it right across the Calgary region. So what Bill does is say, hello, Dr. Norton. This is Bill. Now he's got to do situation. Mr. Smith, the 73-year-old man who you admitted 3 weeks ago, is having trouble breathing. I just took his oxygen and it's at 72. Doesn't matter what it is. He's given me the situation. Background, you remember he's been running on oxygen of 105 on rebreathing. He's still on rebreathing. That's all the background I need. Assessment, I think he's going into respiratory failure. What is my requirement? I need you to come and see him now, please. Well, we're both happy, right? Bill's gone through a script, so he's not upset about anything. And I've got the information I need, and now you have to put other things in place. The next thing you put in place as your organization is rudeness is not allowed. And so if I blow up at this nurse, I'll be on the carpet with my department head the next day. So rudeness is not allowed. That's a really good thing to put in place, and it's something we haven't done well, and that's what the airlines have done. And finally, if I get in, and in fact what was wrong was the person put the oxygen meter on the nose because they forgot it's supposed to go on the finger, and Mr. Smith really is not in problems, I don't blow up. I say, I've got a teaching opportunity. And that is almost a copy from some of the stuff the airlines do. So I think we can learn. But I think we have to be careful and make it fit the reality of medicine. So you're not going to go through that all the time with the nurses. But when I need a critical thing where we have to move together, I want to get the right information passing between us so it works. And of course, you train the docs to respond correctly. I was just...
We're talking about performance standards, and we're all aware, of course, that there's a very close correlation, one-to-one correlation between healthcare and economics. Certainly 30 years ago, an individual who'd come into a hospital with, say, for a hip repair may look forward to spending 3 or 4 weeks in the hospital. Presently, of course, that length of stay has probably decreased to 3.5, 4 days, something along that line. So overall, I think in Kitchener-Waterloo, you may find that 20, 30 years ago, the patient population for Grand River Hospital may have been equal to the patient population for the combined 2 hospitals, St. Mary's and Grand River Hospital now. So you're generally seeing, I think, an increase in patient acuity on units. But I don't think that there has been a subsequent increase in staff resources from both, say, physicians and from nursing staff. And what that translates into is less time to do work thoroughly. And I remember saying on a number of occasions that it seems odd that a nurse may be one of the only workers in a hospital who doesn't have time to read the chart. So if we're looking at performance standards and informatics, time to utilize that information, time to absorb it, and time to apply it would certainly be central to the success and the effectiveness of digitized information systems, and that piece with the ability of hospital staff, from nurses and physicians and so forth, to access that and to utilize it would be key, and probably very difficult to realize.
Well, I think we all understand that the work pressures on the professional staff are extreme at the present time, and that's not a very solvable problem. To train enough docs, to find enough docs to meet the doc gap of 800 GPs in Calgary, the training will take generation. And the gaps in nursing are just as big, and the gaps in specialists are just as big. And so the only way I can see through that is to think about the way we work, because we're not going to have more people. So it isn't even going to the government and saying, I need to hire another 100 nurses. Can't get them even if you got the money. So we've got to think of something different to deal with this problem. I'm particularly interested in knowledge transfer and knowledge uptake, and what I call organizational slack. When I go back to about 1985, when Dominic and I were working on the record, he has trouble with this. 1990, we had what I would call organizational slack in the hospital system. We had nurse educators whose job was to educate, and they had time to reflect. We had nursing managers whose span of control was such that they could actually sit back and say, what's going on in my unit today? And we had enough docs around so that docs could actually spend some time reflecting on practice. That's one of the dimensions of organizational slack. It's gone. There isn't any. And how can we really improve the system if we can't reflect on what we're doing? So we just exist. And I'm just agreeing with you, but I was just phrasing it. And so I think somehow we need to say, for every minute of nursing time, did I have to use that minute? Or could I have let that nurse have some time to think? Every minute of physician time, could someone else have done that job, so that I can get that doc to maximize the health of the community that he or she's living in? But I don't know how to do that. I mean, it's easy for me to stand up here and make these lofty statements, but I have no idea how to reorganize to do that. It's clear from some stuff we've done in the community and chronic disease models in Calgary that reassigning things like the diabetic educators away from a diabetic education center and sending them to physicians' offices have an effect on reducing the pressure of diabetic care for that doc. Patients are happier, and all you've done is just distribute a resource that exists. And the doc gets some education about diabetes automatically, because that happens. So that, you can think of innovative solutions, but you need someone to sit with the light bulb and say, oh, let's try that. When we try things here, it's really important we evaluate them, because we're in a very complex situation. And if you push somewhere in this system, it's a stressed system, which is complex adaptive, it's going to put a pseudopod out, and I want to make sure that's not making things worse. And we don't do a very good job at evaluating at all. You probably all know that.
We have time for one more question.
Hi, Peter. I'm Victoria Sills, Director of Pharmacy, Patient Safety Officer at St. Mary's General. So as always, your comments are relevant today. Human factors engineering and IT applications, and where the science is going with that. We struggle every day. Our computer systems are our blessing, they are our curse. We get flags, we get too many flags. We can find information, we get diluted by information, we can become overwhelmed. Things can even look alike in the virtual world as they do in the physical world. So how are we going to become better with our human interface with information systems in the healthcare setting?
Well, I'm not an expert in that area, so I should possibly pass you on to other folks, but I, of course, have opinions. You don't need to be an expert to have opinions. I think that, some of the questions you asked show me about the gap in basic science here. I think it's a fallacy to think we can take the basic facts of human engineering which are developed in the airline industry and just plaster them on ours. That's just as bad as putting a computer on. We need to take every one of those bright ideas and test it and adapt it, much as I was demonstrating with the S-bar, that you can take something that's really good and adapt it, but it has to be adapted so it works in our situation. So I think there's huge potential for working with the human factors folks, the human interface folks, the ergonomic folks to make things safer. At the end of the day, they have to work with clinicians. We're the only ones that understand and really would bring to the table in a real way the biological variability of the input, i.e. the patients aren't all the same, the complexity of the work, and the incredible focus we have on minute details during the contact. And the fact we don't have a very good ability to step back and get the system's views. So if we can bring that to the table with people that can do it in a real dialogue and we get to where our languages are the same, I think we can make progress. I was pointing out to Dominic, there was a guy called Richard Nixon. Do you guys remember Mr. Nixon? Tricky Dicky. He declared in the 70s, declared the war on cancer in the United States and said it would be solved in 5 years. It's true. You can go back and read the documents. He said that when we didn't even know that DNA existed. Watson and Crick hadn't done their thing yet. When they published Error is Human, the big manifesto in the States, they said in 5 years we'd half medical errors, and we didn't budge them in the next 5 years. I think we haven't done the basic science. Just as cancer wasn't going to be licked until we got the basic science done. Our basic science is different kinds of basic science. It's organizational science and stuff. And there was sure stuff that came from other areas that would have helped in the war on cancer. But you still have to do it specifically about human cells and human cancers. And so, maybe that gives you some hope that, it gives us all research careers and nothing else. So, there you go.
Yeah, I think that there's some beautiful work going on in the people in engineering, for example, here, related to the whole area of interfaces. And there's a huge amount of work to be done. But I know Kathy left, but the work that she and before her Kim Vicente did on environmental interface design seems to be ideal for looking at the challenge of the complex environment of healthcare, including the busyness and the interference in the patient-physician encounter and things like that. So there's some beautiful work underway, but we still have not resolved all the issues. I mean, there's still many things. Peter, there's so many issues, so many questions, so many comments. We wouldn't finish today, but I promised you to get you out of here on time, too. So I just wanted to thank you both for the meeting here and the discussions we've had. It was really great having you here, and welcome to Waterloo.
Thank you.
Well, before you sit down, we have a little gift as a token of our appreciation. It's really wonderfully wrapped. It's really meant to be wrapped so that you can take it on the plane with you. And so thank you very much for coming today.
You.
It's a low-tech gift, but hopefully one that you'll appreciate. So
Thank you.
With that, we'll conclude our seminar. Thank you for coming today. I really appreciate everyone in the audience and the questions they asked. It's been a thoughtful dialogue, and I hope you'll come back and see us again on November 28th when we'll be talking about health informatics education. So with that, good day, and we'll see you again next month.
I just wanted to mention one other thing before you go. On October 29th, there is put together by the students in applied health sciences a talk by the Calgary group led by Tom Rosenall. That's October 29th, which is Monday at 11:30 a.m. in Hagee Hall, something or other, 159, or, you know, remember the number? I actually have the number here. In Hagee Hall, 159. I actually have a memory. I'll hope to see some of you there. The people from Alberta have done some of the most remarkable work in engaging the physicians and other care providers in the e-health arena and getting them actually using things like order systems, computer-based physician order systems. So really quite an opportunity. Thanks very much.